Thank you very much for the opportunity given to me by the organizing committee of the Pandula Revathi Society. Let us proceed with my presentation. It's a thrombocytopenia in pregnancy. Let us see. It's a nightmare for the obstetrician. What is happening is any patient of thrombocytopenia comes in a term pregnancy or labor. Many ideas are roaming in their mind. What they do is handmade availabilities of blood banks, RDPs, SDPs, and then whether go for the routine delivery, what are the problem, what are the consequences we have to face. All these things and ideas are coming in our minds, obstetricians. Many times we come across the obstetricians from Dr. Ellison, he is the first case. He has demonstrated a case of chronic purpura in 1025 in a canon of medicine. It took 99 centuries centuries to take place to describe about the case exactly. After that, helps in lower limit of 150,000 in adults, it is called as. What RCOG guidance they say, all the cases of antenatal who are coming for this one, they recommend to do a platelet count. During routine laboratory investigations, we have to go for the platelet count also at the time of booking or first visit or later at 28 weeks. We have to repeat the platelet count for all the cases. So if we categorize the platelet thrombocytopenia, we see it is a mild thrombocytopenia, 1 lakh to 150,000. It is mostly gestational thrombocytopenia. It happens. Moderate is 51 to 1 lakh. It occurs in HDP, that is hypertensive disorders of pregnancy. Most common conditions we see the thrombocytopenia, and at the severe form, 20,000 to 50,000 severe form. It usually occurs in the genetic conditions. Like I will talk about that also later. See, what are the functions of these platelets? The functions of the platelets are, this is one, maintenance of hemostasis and vascular integrity, thrombosis, coagulation, retraction, wound healing, and immunoregulation are all called by this one. Let us see thrombocytopenia in pregnancy. What is the incidence of thrombocytopenia in pregnancy is about making about 7 to 10% of all pregnancies we see thrombocytopenia. But fortunately, all are normal. Mostly 2 to 3% of cases only need further evaluation of the case to find out the reason why this is happening. And this is divided into physiological and pathological. And physiological thrombocytopenia is always mild, no adverse effect on the fetus or the mother. Due to hemodilution it occurs because increased congestion of platelets, because of the high levels of thromboxane A2 is the one responsible for that. Let us see. What pathological thrombocytopenia is occurs in pregnancy-related cause is the one, like HDP is one cause, and also acute chronic infections of non-specific infections, and or also dengue fevers, typhus, etc. I will talk about that also. And non-pregnancy-related causes are genetic causes. This one, we have to see this. The incidence of thrombocytopenia in pregnancy, if you see, this is the one. 70% of cases it is a gestational thrombocytopenia. Only 15 to 20% of cases hypertensive disorders, and 3 to 4% of cases CV disorders. Yet we will occur for this case. And so Broadly divided the thrombocytopenia pregnancy related causes more common, that is definitely because of the pregnancy that occurs. Non-pregnancy, not at all pregnancy responsible, those also not related to the pregnancy that will occur. The pregnancy related causes are commonly wisdom across gestational thrombocytopenia, preeclampsia and eclampsia Helm syndrome and acute fatty liver of the pregnancy. And are not related to the pregnancy are, we see incidentally they occur. Dengue fever, strep typhus, HIV, hepatitis B and C, malaria, viral infections, rubella, CMA, varicella, parvovirus. All these conditions of infective origin not related to the pregnancy, they may occur incidentally during pregnancy. We come across this one. And nutrition deficiency is one condition. Drug-induced thrombocytopenia, several drugs may cause thrombocytopenia, also statins, etc. And DIC, bone marrow dysfunction, hypersplenism. And due to hereditary congenital autoimmune disorders also they cause thrombocytopenia. They are, we can see, these are immune thrombocytopenia is one, a little bit rare but 1 to only 4% of cases. Autoimmune disorders, hereditary, and thrombotic thrombocytopenia, atypical hemolytic, 1 milligram disease. All these are genetic conditions which may cause of this one. And when the report comes as thrombocytopenia, I just want to advise many people here. When the report comes as thrombocytopenia, don't come to a conclusion. This is thrombocytopenia. Don't refer the case also. Don't be panic also looking at that. Think about it can be pseudothrombocytopenia also. That is laboratory error. Or it can be physiological or pathological. Or it can be autoimmune. It can be genetic also. All these conditions should think in the mind. Any pregnant woman with the platelet count is less than 1 lakh means should undergo further clinical and laboratory assessment have to be done to find out the reason why this is happening for the cases. Indications for evaluation of thrombocytopenia. When to evaluate a case for thrombocytopenia? Total evaluation. The evaluation is it's a known case of childhood. Patient says history that she is a known case of childhood before pregnancy, thrombocytopenia or any bleeding disorder. Or it appears first time, the first and second trimester. What we come across is gestational thrombocytopenia seen in the third trimester. But any patient who is coming in the first and second trimesters, platelet count is less than 80,000 or less than 50,000 also. At any time in pregnancy, we should always think some abnormalities there we have to evaluate. The patient are close relative known to have a bleeding tendency, regardless of gestational age. Also, we have to evaluate the case of that. The points we should think before they coming to a diagnosis is which trimester the patient is and the severity, pre-pregnancy values, associated symptoms, associated lab abnormalities, all these things we have to see. So investigation, first thrombocytopenia, the report comes as low platelet count, exclude pseudothrombocytopenia, repeat the count, peripheral blood smear. If the normal count, okay, leave it, the lab error, no workup is needed. If it is a normal count, proper evaluation is needed for the cases. What all the tests to be done for that case, we have to see. The following tests are, we have to take the family history medications, what the patient is taking, we have to see. Not only that, roll out gestation, TP, ITP, HDP, include fatty liver, lab test, hepatitis B and C, HIV, LFT, helicobacter, and secondly, all viral infections, we have to take these strep typhus, autoimmune disorders, after SLE, antibodies, we have to see screening for antiplatelet antibodies. Test for markers of hemolysis. Platelet aggregation test is one is very important to differentiate from the normal or of genetic origin. We can differentiate that, and also gene studies if possible we have to see, and bone marrow studies also if possible also we can see. But that is rarely it happens. Why TP is important, significant? Why to investigate the case? So because of the bleeding into tissues and left retinal complications, excessive bleeding, so blood clotting mechanism, and it is considered as a high-risk pregnancy for these cases. Effects of TP. Take into consideration. Diagnosis is by diagnosis of exclusion. So what is the diagnosis? It will do all the lab tests about last slide I have mentioned here. Rule out the cause. Platelet aggregation test to differentiate from genetic platelet disorders, and the anti-platelet antibodies screening if possible you can do, and not readily available most of the times is not helpful. And before taking the management guidelines, let us know about two conditions, pseudo-thrombocytopenia and thrombocytopenia post-transfusion thrombocytopenia. We have to see what are these. Pseudo-thrombocytopenia. What is this pseudo-thrombocytopenia? It's a spurious thrombocytopenia is a laboratory impact because of the ETDA anticoagulant is giving rise to clumping of this one. If the clumpings are there, the technician cannot count those clumps into the counting, so the results will be low. So in this case, this will occur. This is the example for that one. Mechanism. What happens here in this case is how to differentiate whether it is true or pseudo. The machine cannot count the clumps, so we have to make a peripheral blood smear we have to do and repeat the sample or hemogram if necessary. That reduces the patient's anxiety, physician's anxiety, and prevent the patient's referral. Okay. Treatment. The prevention is the one. The prevention of this condition is increase the anticoagulant. No specific treatment is needed. Dilution of this, I am skipping this slide also. Discussion on pregnancy-related causes. Gestational thrombocytopenia. Gestational thrombocytopenia, I wanted to, it's making about 75% of cases, preeclampsia, eclampsia helps in over 15 to 20% of cases. All these factors produce thrombocytopenia HDP because of the pathological process that is taking place in the placenta and endothelial dysfunction and coagulation. And common cause you can commonly see totally the patients are asymptomatic. Only incidentally the case is diagnosed in anterior hair only in the second trimester without any symptom. Actually we can say it's a benign condition. Recurrence recurs in the next pregnancy. Similar to that of ITP, we have to differentiate it. ITP sometimes we feel difficulty also between the two conditions sometimes. This is the differences between gestational thrombocytopenia and ITP. Gestational thrombocytopenia 75% of cases, ITP 3%. Time of onset, second and third trimester, early trimester, asymptomatic spontaneous bleeding, no previous history, the next more than 6,000, 50,000. So these are all the differences between gestational and ITP. The causes of gestational thrombocytopenia, the pathophysiology is not hemodilation is the main cause for this condition. Hypertensive disorders, all these conditions will cause. The mechanism here is what happens is hypoxic placenta, microvascular endothelial dysfunction. The cause is platelet activation, increased consumption, giving rise to thrombocytopenia. And because the thrombocytic preeclampsia is always mild, is hardly less than 20. Once it comes, any count is less than 1.1, we have to go for the termination of pregnancy. If required, steroids and immunoglobulins have to be given. The return to normal within 3 to 5 days after delivery. No risk of sudden pregnancy. Acute fatty liver unmet condition also causes thrombocytopenia. Thrombocytic hereditary conditions are rare inherited genetic platelet disorders, lifelong, life-threatening bleeding tendencies, low platelet count with abnormal plant function, platelet this one. And the causes of genetic mutation for all these genes, ADAMTS 13 gene, MIHL gene, GP1, beta alpha gene, X-linked genes, autoimmune gene are responsible. The triggering factors for the development of these conditions are disturbed immune system, anti-platelet drugs, immunosuppressive agent, HIV or syphilis, acute viral infections, all these conditions, anti-platelet antibodies or platelet disruption takes place, destruction. Symptoms are there. Management of the case is almost more or less similar to all these conditions, whether the pregnancy, hereditary or genetic or the conditions are. I'll skip all these things. Premarital counseling is important for the cases. I'm skipping all the slides. Yeah. Premarital counseling, pregnancy planning is important medically displayed center. Counseling has to be done to reduce the anxiety of the obstetrician and patient's relatives and everything. Multidisciplinary antenatal care, all the facilities of hematologist, coagulation, blood bank, all these things have to be available. Avoid infections, avoid traumas, accident, neosis, IM injections, good hygiene, health and vaccines, periodic monitoring platelets every 2 weeks, maintain platelet count always above 50,000, higher chances of freedom level of all this. Nice guidelines, they say target goal is more than 30,000 toward the pregnancy have to maintain near 50,000. near term. 50,000 safe for the delivery, 70,000 safe for anesthesia. Asymptomatic case 30 to 50,000, no treatment, and platelet count less than 10,000, go for this steroids and immunoglobulin have to be started. Indications of emergency platelets is not indicated SVP, only genetic conditions less than 50,000 we have to go for platelet transfusion. Either RDPs, SVPs we have to give for the conditions. And supplementation of all this we complex. Planning for delivery only testing care center where facilities for 4 FFP, 4 RDPs have to be resolved at that time prior to the delivery. Before 36 weeks, 10 days prior, first line of drug is prednisone have to be given to avoid risk of bleeding, suppression of immune system, safe and effective for 2 to 3 weeks is one. And coming to platelet count less than immunoglobulin have to be steroids and thirds who are resistant to refractory conditions. Delayed clearance of this one. They are very expensive. Drugs that boost up in thrombopoietin, other immunosuppressants. Fail to respond oral algicoprid danazole have to be given. Splenectomy is not usually indicated in very rare cases less than 10,000. Second trimester is indicated. And was indicated. Delivery always in cesarean section, normal delivery, or obstetric indication, not platelet indication. Anesthesia spinal count we have to look at. Safe is more than 80,000. Platelet have to be don't there is always safe award of later deliveries. About feeding blood sampling, delivery time is active and third stage of labor have to be done for the cases. Now the cesarean section count is less than 50,000. One obstetric indication, platelet transfusion have to be given. Prior to surgery, I told you already, platelets have to be resolved for the cases. And conclusion is conclude here. Conclusion is 5 to 10,000 during pregnancy. Gestation ITP most common 75% case. Target goal is more than 30,000 over pregnancy have to be maintained for this case. 50,000 safe for the delivery. Prednisone IV immunoglobulin have to be maintained. CS is done, platelet have to be resolved for this condition. Splenectomy very rarely, unresponsive cases, second trimester. If necessary, only we have to go ahead, especially genetic causes of cases. Rest of the cases, no. Thank you very much for the opportunity given to me. And technically, there is so much a problem prior to that, but thing is, we have successfully completed this one. I hope I have taken a little more time. I thought that this will be useful. What are the time allotted for anybody? 15 minutes is not at all adequate to completely cover the subject. That's what my request. If it's 20 minutes, it's good, but it's not possible. I can't force anybody, like that to increase the time. Okay, thank you very much for the opportunity given to me once again.